Hello, my name is Gracie O'Reilly, and this is my case study 2 for SPCE 683, section 805. The date is October 20th, 2024. Jumping right into an overview of this case study, we will first review the target behaviors selected for intervention that was mentioned in case study 1, and we'll touch on task list items H1, H2, H3, H4, H5, H6, E2, and E7, which are laid out on this slide. There are currently 3 target behaviors being measured and intervened on for this client, which are screaming, self-injurious behavior of head banging, as well as tantrum. The operational definition of screaming is any instance in which the client emits an elongated noise, which may be high or low pitch noises resembling screeching, shrieking, yelling, etc., for at least 1 second. Each new instance of screaming is separated by the behavior being absent for 5 seconds. The operational definition for head banging is any instance or attempt in which the client moves her body in any direction resulting in the front, side, or back of her head making forcible contact with a hard surface such as a desk, the wall, a cabinet, the floor, door, window, etc. Each instance is separated by the client removing the contact between her head and the surface. And finally, the operational definition for tantrum is any instance that the client engages in 2 or more of the following behaviors for 20 seconds or more. Elongated vocalizations, resembling whining, yelling, screeching, etc., with or without tears. Throwing her body to the ground, in other words, flopping or dropping. Flailing her arms and or legs. Head banging, throwing, swiping, hitting items around her, or in other words, property destruction, and or physically refusing to get up or move from her current location. Each new instance is separated by the behavior being absent for 2 or more minutes. There are examples and non-examples below each of the target behaviors as well. And frequency data is being taken for screaming and self-injurious behavior of head banging, and then duration data is being taken for tantruming. I will now get into the behavior reduction or intervention goals per behavior, which coincides with task list item H1. For screaming, the goal is that the client will decrease the overall frequency of screaming from baseline levels by 90% for 3 consecutive months. For the self-injurious behavior of head banging, the goal is that the client will decrease the overall frequency of head banging from baseline levels by 100% for 3 consecutive months. And then for tantrum, the goal is that the client will decrease the overall duration of tantrums from baseline levels by 80% for 3 consecutive months. Provided on this slide is the Functional Behavioral Assessment results derived from the Motivational Assessment Scale 2 or MAS-2 for the target behavior of screaming. I will be focusing on that behavior of screaming for the remainder of this presentation, but provided is the analysis, which shows that the number 1 ranked function was tangible, then following that was attention, escape demands, and sensory. The graph of that is also shown below. These results gave rise to what the intervention would be for this behavior. Laid out on this slide is some antecedent interventions and other strategies for screaming, which coincides with task list item H2. We have functional communication training, which can be implemented in a variety of ways. We have positive punishment, which would be a last resort. An example of this would be saying no screaming or quiet mouth as the client is engaging in screaming. We can utilize the PREMAC principle or first then language, which could be implemented as an antecedent strategy as well as when the behavior is occurring, as well as teaching replacement behaviors, which somewhat overlaps with functional communication training, as that is going to be the main replacement behavior for screaming. And we could also utilize concepts from the universal protocol, so reinforcing more mild behaviors or precursor behaviors to prevent more severe behaviors from occurring in some. This slide is somewhat of a continuation from the last and also touches on H4 and H5 task list items. So some more antecedent interventions and strategies for screaming include gaining and assessing motivation, gaining and maintaining joint attention, offering choices, sanitizing the environment, and I once again emphasized functional communication training in a more specific manner. So we want to be focusing on manding for action, manding with carrier phrases, and manding for escape, and continuously modeling those phrases. Some additional notes with this is that a variety of communication phrases prevent overgeneralization of certain phrases, which is a potential risk and unwanted effect. Functional communication is feasible across settings and can be easily generalized. It supports environments, and if visual aids are used, for example, those can be easily transferable. Communication is also more socially accepted than screaming, which enhances the social validity aspect. The consequence response I came up with for screaming was to remain calm and neutral and not make any statements related to the behavior while immediately interrupting the behavior by prompting functional communication. We will remain within 1 to 2 feet and on the client's level in case the behavior increases in severity or the topography of it changes. For example, if a tantrum starts to occur or head banging occurs. This way we can intervene as needed. We will allow the client 3 to 5 seconds to echo the functional communication phrase. If the client does not echo, we will follow error correction procedures for manding, as the client does have a few manding targets in. Once the client vocally echoes the prompted functional communication phrase, we will provide behavior-specific praise for the functional communication and honor the request. We will then continue with session. Client progress and treatment integrity will continuously be monitored, which coincides with task list item H6. Depicted on the screen is the graph for screaming. We see that it's somewhat at the same level, but it does decrease a little bit at the end. This graph depicts when the screaming operational definition and consequence procedures were put into effect. For treatment integrity measures, after the procedure was sent out to the client's team of RBTs, follow-ups were done by myself and the BCBA to ensure competence. RBTs are supervised at a minimum of once per week, in which myself or the BCBA ensure the intervention is being applied as designed. Regarding assent and consent, which coincides with task list item E2, depending on if the work demand is negotiable or non-negotiable and requires follow-through, for example, to maintain client dignity, clinical judgment can be used when determining if mands for escape should be prompted and honored. Really, any mands in that matter. Parents have approved and are in support of functional communication program interventions, as well as the antecedent and consequence procedures created and now implemented. Also, procedures mentioned are fairly non-invasive and often only require prompts that are at a lower prompt level than physical prompting. So that kind of helps out with the idea of assent. Lastly, we will touch on cultural considerations, which coincides with task list item E7. The client's family did not mention many cultural specific concerns or information, but when they do, it is our job to delve into that conversation to have a full understanding of the situation at hand and desired behaviors given certain cultural circumstances. From there, collaboration with the family needs to be emphasized to ensure we are both intervening on behaviors in a similar way and that us as BCBAs have an understanding of what the desired behavior in certain circumstances is. One cultural consideration the client's mother did share is that the family does primarily utilize punishment procedure. It is our job as BCBA to take that into consideration and train them on reinforcement-based interventions. We want to consistently show respect and openness towards cultural factors and evaluate the value the client's family and stakeholders hold for certain skills and behaviors. When assessing, we want to consider certain subdomains that may not be applicable to the client. For example, if a client doesn't have the certain type of hair that requires daily brushing, that should not be scored against them on an assessment domain that scores that skill. Instead, the subdomain should be avoided. We always want to gain consent from the client's family and stakeholders regarding interventions, especially those that are aimed towards cultural considerations before intervening on them to deem that they are appropriate. As always, we want to continue ongoing research and education in cultural factors that we may not be fully competent in as a BCBA. Thank you for joining me throughout my case study. I hope you enjoyed.